We're a small group. We can do them without the.
Okay. Do you want to kick off, Sarah?
Yeah, because
yeah,
pull us out the room.
I think since we're such a small group, if the people who are in the group don't mind turning their cameras on and because I think we can actually do a reasonable amount, but it'd be really useful to get some input. So I don't know whether people would like to just introduce who they are and where they're from.
Does everybody want to put the cameras on, please? If you can.
If you can,
or just say hi. Alison. Oh, Alice is there. Sorry, Alice. Alice, do you want to say where you're from? Oh, we can't hear you. Sorry, Alice.
Can you hear me?
We can hear you. Yay!
Headphones in. So my name's Alice. I'm from Brooklands Medical. I'm doing a dual role, practice nursing, and just finished my ANP course.
Brilliant.
Yeah.
Oh. Then look.
Louise, are you able to say hi? And Lindsay. Oh, Lindsay doesn't have a camera or mic. Okay. So I'll just say who I am.
Yep.
So I'm Moira Rogan-Sarkin. I'm one of the lead nurse educators and professional nurse leads for Greater Manchester for the practice nurses, and also was a practice nurse in Salford, so do a lot with know a bit about practice.
So what we were planning to do, this we were hoping to do, and we have created some case studies, but we may just have to give them to you verbally rather than, was just to work through 2 or 3 different scenarios of patients to work out how we can improve the early diagnosis of cancer for those groups. So I think that we had, I can't if we just say a man, so basically to look at it from both a screening point of view and from an early diagnosis point of view. So we were going to look at bowel, lung and breast cancer. I suggest that we probably start, because there's the most to be done probably on the bowel cancer, and if we just look at, you know, a patient who I don't know where Lindsay and Louise are from. I know where Alice is from. I know where Brooklands is, but I don't know where the other medical centres are, which parts of Manchester. But if we're talking about, have you got the details of our bowel cancer patient? Oldham, right? So basically, if we were to imagine a patient in the mid-60s with who is eligible for screening treatment. So obviously the best thing we can do to start off with is to try and increase the screening. So I suppose it's just, what opportunities do we have? How do we do it? What thoughts people have got about how we can improve screening for that group of patients, bowel cancer screening, particularly the disadvantaged groups, because I think they're the ones that we particularly don't reach. So I don't know whether anybody's got any experiences, any thoughts, any things they feel that could be done. So the part of this is what can be done within practices, but part of it from our point of view, being a bit selfish about this, is what can be done, what we could do to help you do that. So we have got for the bowel cancer screening, we have got a whole heap of translated leaflets now in all sorts. There you go. Well, let's start with Greg, 71-year-old Afro-Caribbean man, lives in central Manchester. How can we encourage Greg to do his bowel screening? What stops him coming? I don't know whether anybody's got any thoughts on what's, how we get these groups in, because it's not easy, and you can translate that into lots of different scenarios. I don't know whether, Alice, you're the only person who's on camera, but have you done any work on the FIT stuff on FIT bowel screening within your practice or your PCN?
No, I haven't dealt with anything, but I just know on EMIS it does pop up if they've not taken part in the bowel screening.
Okay, so would it help if I just, so the bowel screening is available at the moment for people between the ages of 60 and 74. It's a one-off test now. It's now done by FIT rather than FOB, and that changed a couple of years ago. The advantage of that is that it's one test for the patient. What the patients didn't like about the FOB test was that they had to keep the poo around for a few days while they produced 3 samples. So the FIT is it's easier for the patients to do, and it is more specific, so you're much less likely to get false negative rates and you're less likely to get false positives. It's really important to remember that with the FIT, particularly, that for when you're using a screening test, you're looking for a level above 120. When we use FIT in the lower GI, in the colorectal symptomatic pathway, we are using FIT at a level of 10. So if you've got a patient who is symptomatic, a negative, a bit like a smear, negative FIT test is not particularly helpful, because they could still have a level of 110, which is quite high, and not be picked up as positive by the bowel screening team. So that's a really important distinction for everybody to get, and it's put on almost every bit of teaching that we do, just to make sure that people realise that. So if you've got patients who you get an alert that they haven't done this when they are eligible, they can ring for repeat tests to be sent out for them. I think one of the problems is that the tests come out from the screening centre, and they do look a little bit like junk mail. So I think patients don't open them. They've not got practice headed paper. All of it. So I think patients, it's quite easy for people to ignore them if they're not looking out for them. But if they have ignored it, they've thrown it away, they can ring the bowel screening number to actually access a further test. If your practice is particularly keen on supporting people to do this, you can actually do some training via, I think Answer Cancer are now doing it, but if you let us know, we can sort out who's doing it, to actually request for the patients. If you've got a group of patients who you think actually won't be able to request the test themselves because the process will be too complicated, or they don't speak English. Actually, if you do it's a small amount of training. It's basically just to make sure you understand what you're asking for the patients. Practices can keep a list and actually request them for the patients. We've produced all sorts of leaflets, haven't we? We've got, and they're all on the GM Cancer website, aren't they, Ali? All of the bowel screening leaflets in how many? Lots of different languages now to support your patients. So if you've got a non-responder, you can send them a text with the details of why it's important and how to do it in their own language.
So sorry.
No, you carry on.
Yeah, so how can I find out what the rate is at my current practice? You know, people responding. Is there a search then?
Ali. Is the screening on Tableau?
Well, it is, but it doesn't go down to practice level on Tableau, but your own practice should know that. If you speak to your practice manager, they should be able to access the information on there and see if they can see it. It doesn't go down to practice level at a national data level, but you can look on Fingertips, so you might, which is a data system. So I'm just thinking, on the back of a couple of the questions that came up when we were showing the slides earlier on the call, and then your question there, would it be helpful, do you think, if we just sent a bit of a summary of the questions that we've been asked and where you can find that extra information?
Yeah,
so we can send you the link.
The leaflets in different languages and the text messages, that would be helpful for our practice. So, but I don't know where to access them.
We can also put the things like the safety netting template. We can put details of that on there, can't we? We'll get we've got a new member of staff who seems to be very good at this sort of thing, and we can get her onto putting a list of useful. So if we then circulate it, they can go around all the practice nurses, because we have sent it to every PCN, but actually I know that not everything filters through at the right levels everywhere. So you can have all of everything that we've compiled as useful information for smears and for bowel screening.
If we just kept
really
that just
helpful.
if we kept it just to like a single side of A4, no more than literally just a list of some of the key points. And I would say one of those possibly needs to be to everybody who was on the call today, find out who your PCN cancer lead is.
Yeah.
Yes,
I know for me, I was trying to find what is a smear in Ukraine, you know, for the Ukraine people who are coming across, and I found it really difficult. I found one in Scotland eventually, but it was like 8 pages long.
Yeah.
Which was just too much. So I'd kind of thought, well, we can't do that. But, you know, we have these refugees and coming suddenly, we have the Afghanistans who we've no smear history, but we need to be taking smears, but they don't understand about smears. So it would be really helpful. And we've got a large Jewish population that we're targeting at the moment. And again, they don't really understand about cancer. Well, they do understand about it, but it's not important in their lives, I don't think, and it's trying to engage them.
Yeah.
So what I will take away from that, though, Moira, is I'll go back to our comms team. We've actually got a call with them tomorrow and just check what is available in Ukrainian, because
I could only find something in Scotland. I looked on Joe's Trust and I couldn't see anything there. And this one was in Scotland, and it was about 8 pages, eight A4 pages long. I thought by the time you printed that out and sent it, they would have
they're not getting past page 4 for one, were they?
And we've got some core patient leaflets and sets of information that, as Sarah's already said, we've had translated into a number of different languages. So all we'd need to do would be to send those 6 or 7 things to the organisation that do those translations for us and say, we've had them in however many languages, we've got them in now, 20 odd different languages. Can we have the same things in Ukrainian? So it's things like the lung, prostate and colorectal leaflets that patients are given when they're referred, the leaflet about a cancer referral. So just some of that basic stuff we can sort.
And I know now when on the new patient checks, we have to ask the ethnicity and the language. So that will, we could pull that data from the practices and maybe send, if they're in Russian or whatever language they speak, we could target them. It would be fantastic.
Yeah, because we've got all the 2-week wait information, you know, the things to send if you send a patient on a referral. We've got those translated in lots of different languages as well, so it'd be useful for people because a lot, presumably Alice, you'll be doing if you've just completed the AMP's training, you'll be doing referrals and such like, so it's useful for you to have access to all of those things.
I've done a few lower GI referrals, but obviously I'm still
So for your lower GI referrals, if you've got a symptomatic patient, obviously we're sending the fit test with all of them. There is on, do your practice use AccuRx or Manchester?
We use AccuRx.
So if you look on AccuRx and search fit, there is a template on there which gives you the option to send a text on the day that you ask the patient to do the test, saying this is why it's important and this is how you do it, and then it automatically schedules a reminder text for 3 days later, so that you are prompting the patient just in case they haven't done it. So that's a useful thing. So I don't know, we've been constantly telling the PCN cancer leads this, but I'm not sure that everybody's actually found it yet, so it's just useful to remind. So is there anything else that obviously the other thing with the bowel cancer screening is that there will be the age extension, so they are starting to bring the age down, so they're going to be inviting 56 and 58-year-olds soon, so that's, you know, just not to be surprised. So it should be going down to 50, I think, isn't it, Ali? 50 eventually, but not quite yet. So if we leave is there anything that you wanted to think about or ask for bowel symptomatic patients or screening?
For me, or
either anybody who's
no, I tend to just go on because I always get confused. So I get a patient that presents with change of bowel habit. I always go on NICE guidance and just see are they eligible 2-week wait. So I can't remember it all, but I always go on the NICE.
No, that's fine. That's where I go if I want to look something up. I think it's just that bit, remembering that actually not all the patients fit the age guidance, but the actual general sort of gist of it guidance is that's what I would go for NICE for all of the guidance really. I tend not to use any of the other decision support tools that are out there just because I like this one particularly. Is there anything? So if we talked about the breast cancer patients, is there anything on? I mean, I think the breast symptomatic patients are much more straightforward because they tend to have quite a high awareness. The screening is as just screening rates in Manchester in GM are just going down and down and down.
Partly so I was just thinking, you know, all this information you send to the PCN leads at the moment, and I don't think sometimes it's cascaded out to the nurses who are the ones on the ground doing the work. I wonder if you send it to the what we used to call the CCG lead nurses. So for me, I'm Salford's, and a lot of them are on this call today. So like Henrietta is Trafford's. And so across GM, there's always a lead nurse. We use them as the CPD training a lot of the time. But I think if you send them, they have the list of all the practice nurses within their localities, and they could disseminate your information down to them. I do a monthly newsletter for all the nurses in Salford. So I usually find training courses and things. So if it was sent to me, I could put it in the newsletter, or if it's a big lot of like your leaflets or a link to the leaflets, I could disseminate that to the nurses. So it would be really useful if you use the nurses, the lead nurses at the locality, rather than the PCN. Well, it's great that you're using the PCN Cancer Champions because that's what they're there for. But I don't know for Alice whether she's getting the information. I know a lot of our nurses aren't getting the information. So it would be really useful.
Yeah. So can someone send me a list of who those 10 are?
Yeah, I'll send
brilliant.
You. Yeah,
that would be really good because we do try and get the cancer commissioning managers to send things out in their localities as well.
A lot of the time they haven't got the updated nurses list.
Yep.
You know,
I suppose
because
I would
we're
have hoped
kind of
that
on the ground and we know who's getting a new nurse in, who's retiring, who's moving to what practice. We've got such a big cohort of new nurses. I think in the last 18 months with the GPN Foundation course, they trained over 100 new nurses across Greater Manchester.
So would it be useful to ask Lauren to send you all the back copies of the PCN bulletins as well? Because there will be that's you're looking like that might be.
That's a lot. We've done one a month for the last 12 months. That's quite a lot, and they have a lot of attachments with them.
Oh, do they? Oh, don't block me inbox. I've just
I know that's what I was thinking. That's why I was but that was the reason for the face pull. I was thinking
all weekend to get like 75 gigabytes or whatever. Kept telling me was over. It
would push you over that edge. But yeah, I can send the last couple of months maybe, and then that would give you a flavour of what goes in. I can then just take
out bits that are relevant, and then for training I can put bits in for those.
Yep.
Yeah, that's really helpful. That's a really good idea, isn't it? And is there anything, you know, just in terms of what your practices do in terms of encouraging women to attend breast screening? How easy is that? I mean, I know it's been it's been quite difficult over the last couple of years, particularly as they stopped the Times appointments. I think that made a big difference. Most places are now back to giving timed appointments, aren't they? I think. So what happened was that certainly I've just had mine done in Stockport, and you had to ring to say that you were interested, and then you got a letter, you had to ring and engage with the letter, and then you got sent an appointment in the post for an appointment about 4 weeks later. I'm not surprised that a lot of our patients fall by the wayside with that process because it's too long drawn out and there's too many steps in it. So they are now going back to just sending you an appointment for 3:27 on a Thursday.
Yeah, I got one the other week for 9:51.
Yeah.
Yes, in the car park at Booths. So yes. I trotted.
Yes. I went to a car park in Edgeley. but I think it's better that they are now doing. I think that they did have a big decrease in uptake at that stage. But do you get advance notice that people are coming and that the van's coming to you?
Not that I'm aware of. I don't think we get it. I know some of the nurses do when they're doing the cytology. They do mention about the mammograms or they do in our practice, and ask if they've had one regularly. But we don't know where the vans are, so we couldn't kind of signpost that there's one at Morrison's in 3 weeks' time. That would be good if we knew in advance where the vans were in each area, so that should a lady come in, we can then signpost them. Or I think they've got the Nightingale telephone number, haven't they, that they can ring. But you know what ladies are like sometimes. Their lives are chaotic at the best of times, and you know, to ring, whereas if a letter, they might just turn up. I think maybe if they could have some slots where they could have almost like a drop-in, you know, if you were going to do your shopping at Morrison's and you knew you were due a mammogram, could you drop in? I'm not sure how that would work.
We can speak to the screening. We're starting to work. I mean, it's part of the problem that we have is that we're not actually responsible for the screening, but we sort of are. So it's sort of we're there to try and make sure that what rates are reached, but we can't. We don't commission. We don't do it. But we can speak to the team about. I think we probably need to go back. We need to meet with them anyway, don't we, Ali? About going back and just making sure that they have processes that, again, we probably share with various different forum about how you know that the van's coming to your area in the next few months, so you can start to do some.
Yeah, and I wonder if we knew the vans were coming, we could just send a text out to them saying Morrison's van, there's a van in at Morrison's car park. But then it's if they just turned up and you had one last year and you're not due, they wouldn't have any records, would they? I know they asked the questions, have you had one in the last 3 or 5 years? But you could have some women, you know, like they do for smears, they just turn up even though they're not due.
Yeah.
And then I think that's a bigger probably project.
Yeah, we'll have a word, at least making sure that you knew it was coming. So that you
we could just send a text out to those that we
just say, look out for your invitation. It'll be in the post.
I don't think we get a list of who's been invited as well till after. I think it's after when they don't attend is when we get the list saying your lady didn't attend.
Yeah, because we had a couple of issues with them where they'd invited people who had just been diagnosed with breast cancer and then sent them DNA letters, which wasn't very unfortunate. So we need so we can have a chat about that and just see. And presumably you're not. Are you in the lung health check area? If we move on to, because I know we've only got another.
Salford is doing the lung check,
So what's your practice involvement in that?
So for me, because I'm not actually involved in the practice, although I've got an overview of Salford, I know Eccles and Earl, they've done Ordsall and Claremont, they're doing Eccles and Earl at the moment. I don't know what the uptake rate is. I've not been on any meetings to say what the uptake rate is. So, but I can get some information.
I think it's more the other way around. It's whether or not the level of information that you're getting as nurses is what you need to, because you'll be doing a lot of the checks on COPD patients who will be the high risk patients. So it's useful to know what the lung health check is offering, so that if people are asking you about it, so I suppose it's whether or not you've got that level of information.
I don't think they have, but I can check on that. So for Salford, we don't do spirometry anymore in practice. They go to the diagnostic unit now, and for Pheno the same. That's been commissioned through Salford Royal, so we don't do any spirometry. So for the majority of the COPD, it's done via telephone reviews still.
Yeah,
because what they'll do is just for the diagnostic bit, they kind of just signpost them.
But that would it's still important, isn't it, if you've got that patient who has just had an invitation, or you think might be due an invitation, that they're encouraged to go and do.
Yeah, I don't think there's been much information. I think I've only read about it through Facebook. I think, you know, when the things pop up saying we're doing lung cancer in your area. And that's mainly because of the patients, you know, it's more patient information.
So
go on,
sorry. So I think there's a few things from these conversations today, even though there's only a few of us on this, it's really helpful because there is a Greater Manchester Lung Health Checks programme board that leads all of that lung health checks work in the existing 3 areas, but also the plans for the future rollout. We've got a meeting tomorrow, and we've got somebody starting in a project management role, and what I wanted him to focus on was a lot of the engagement and the community stuff and making sure that those messages are out there. So I'll make sure that the practice and community nurse network is part of that program of engagement. Because
do we have leaflets in practice?
You will do. The patients who are referred on, not referred, who are invited to go into that lung health checks program will receive information, and their
do the nurses have anything to hand to be?
The practices are involved in it, so that's what I'm picking up on, that actually we just need to make sure that when that happens, it's not into a black hole somewhere, and that you specifically as a network know what the rollout program is, know where it's going and when, as of next year, when it starts to.
And I'm just wondering if, for those that have been invited, whether there's any code that we could put on the patient notes. That
there is,
or is there a code
that
they've been invited? Because then that might prompt, you know, like, so if you're doing your COPD review, you could say to the patient, oh, I noticed you've been invited for your lung health check, have you been yet? You know, and then that kind of prompts the patient to say, oh, I didn't really know what it was about. I thought this was me annual review. And they just think that's something else. So they might think the lung health check is just an annual review. Well, I always go to the surgery for my annual review, so I'm not going to go. So if it prompts the nurse, and I know it's not part of QOF or, you know, but if it's on the EMIS or Vision, that just a pop-up kind of comes, have you asked about the lung, has the patient attended lung health, yes or no? Do they need more information? And then if the nurse knows about what goes on in the lung health check, they can say, well, they'll be doing this, this and this.
We're going to disappear. Sorry, that's me. Sorry, Alice, there's me talking. No, that's really helpful.
No, that is helpful, definitely.